Usually when you go in for a minor procedure, there is this expectation of a clean fix.
Right, like getting a cavity filled or something.
Exactly.
Yeah.
Yeah, it's pitched almost like that. You
Yeah.
go in, they patch up the issue, and you just go on with your life. But imagine you are in that scenario and you've recently had a urethral bulking injection.
Which is usually something like Bulkamid or macroplastique, right?
Yeah, for stress, urinary incontinence. And hey, the incontinence might actually be significantly better.
The procedure itself worked.
It worked, but now you are dealing with a completely new problem. Because every single time you pee, you experience this persistent, agonizing, burning sensation. Dysuria.
And, I mean, the immediate assumption for anyone in that situation is going to be a urinary tract infection.
100%.
Because the symptoms mimic a classic UTI almost perfectly.
Yeah.
The burning, the urgency, the constant discomfort.
So you do the logical thing. You go back to the doctor and they run a standard urine culture and it comes back completely negative.
No infection found.
Nothing. You are left sitting there in incredible pain with a piece of paper that basically says you are perfectly healthy. So our mission for today's deep dive is to figure out exactly how to handle that scenario.
Right. What do you do when your urinary tract feels like it's actively on fire, but the standard medical tests say you're totally fine?
Exactly. We are pulling from a stack of clinical trial data, urological management guidelines, and the Cleveland Clinic's latest dietary protocols to map out the clinical management of this very specific, very frustrating condition. Okay, let's unpack this. Before we can even look at treating the pain, we have to establish the physical mechanism.
We need to understand why the urethra is burning if we were supposed to believe there's no documented infection.
Right.
Well, we have to look at the physical reality of the injection mechanism itself. I mean, these bulking agents are marketed as minimally invasive.
Which they are, I guess, compared to like major pelvic surgery.
Yeah, they are, but they still involve a needle repeatedly entering a highly sensitive mucosal environment. Yeah, exactly. The physical act of the procedure causes microscopic scratching and trauma to the urethral mucosa, which is the delicate inner lining of the urinary tract.
Okay, so that localized physical trauma initiates an inflammatory cascade.
Right. It causes localized swelling, and in some rarer cases, it leads to fibrosis.
Which is an abnormal thickening and hardening of the
Fine.
tissue right as it tries to heal.
Exactly. The tissue is essentially scarring over and staying angry and inflamed, regardless of whether bacteria are present.
So it's a structural damage issue causing a systemic flare-up.
Yeah. And this specific inflammatory response triggers a broader condition known as urethral pain syndrome, or UPS.
Okay.
The defining characteristics of UPS are this chronic irritation, a deep burning or aching pain localized in the urethra, and a frequent urgent need to urinate.
Which sounds exactly like a UTI.
Right. But more crucially, the body's reaction to this localized urethral pain often causes the surrounding pelvic floor muscles to go into severe spasms.
Oh, wow.
Yeah, compounding the pain entirely independent of any active bacterial infection.
Okay, I'm looking at this from the patient's perspective here, and I have to push back on the premise of the negative test.
Go for it.
If the pain is that severe and the pelvic floor is spasming and it feels fundamentally identical to a raging infection, why are we blindly trusting a standard 24-hour urine culture that claims nothing is there?
It's a great question.
Like, is it possible the testing methodology is just fundamentally flawed?
Well, you're completely right. The standard test has massive diagnostic blind spots. And acknowledging those blind spots is really step one in modern clinical management of dysuria.
Okay, so a culture negative result on a standard lab report does not definitively guarantee an infection-free urinary tract.
Not at all. The standard urine culture, or the SUC, is still widely considered the gold standard in general practice, but it operates under severe limitations.
Right, looking at the literature here, the SUC only incubates the urine sample for 24 hours, and it does so under aerobic conditions.
Right, it's looking for fast-growing bacteria that thrive in oxygen.
But the urinary microbiome is much more complex than that.
Oh, absolutely. Our sources point directly to advanced alternatives for this exact reason. Specifically, the expanded quantitative urine culture, or EQUC.
EQUC.
Okay. EQUC fundamentally changes the parameters of the test. So instead of just using standard nutrient plates,
Yeah.
it utilizes different, richer media, like chocolate agar.
Which, despite the name, is just a media made from Lenist red blood cells, right, to provide a denser nutrient profile.
Yeah, exactly. It has nothing to do with chocolate.
Yes.
It's designed to feed the fastidious bacteria, the strains that are incredibly picky about their growth condition.
Right, they refuse to grow on the cheap stuff.
Exactly.
Yeah.
And more importantly, the EQUC protocol mandates incubating the samples for a full 48 hours in an anaerobic environment.
So you're starving them of oxygen and doubling the timeline.
Right, and the results of changing those two variables are staggering. The clinical data shows that EQUC yields a 5-fold higher bacterial count than standard cultures.
Wow, 5-fold higher.
Yeah, it routinely detects diverse, stealthy bacterial species that the standard 24-hour aerobic test completely misses, with Staphylococcus hemolyticus being a prime example.
Okay, so that's a huge blind spot.
Huge. And beyond even the EQUC, clinicians now have access to next-generation sequencing, or NGS.
Right, NGS bypasses the growth phase entirely, doesn't it?
Exactly.
It just scans the sample for bacterial DNA. It doesn't matter if the bacteria are alive or dead or refusing to grow in a petri dish. If their DNA is in the urine, NGS finds it.
Exactly. Therefore, before a clinician confidently diagnoses pure urethral pain syndrome caused solely by injection trauma, they have a responsibility to utilize these advanced diagnostics.
Makes sense.
The management pathway must ensure a slow-growing anaerobic infection isn't simply slipping past an outdated testing standard.
Okay, so let's assume the patient goes through that rigorous diagnostic gauntlet.
Right. They get the EQC, they run the NGS.
And the results are still definitively negative. There is no hidden bacteria. We are dealing with pure, unadulterated urethral pain syndrome stemming from the bulking injection trauma.
Okay, in that scenario, the first phase of clinical management involves what the sources describe as foundational treatments.
Meaning behavioral tweaks and oral medication.
Right. The initial approach is always the least invasive. We start with physical therapy, specifically pelvic floor physical therapy.
To directly address the muscle spasms we discussed earlier.
Exactly.
And this makes physiological sense. I mean, if the urethral lining is physically damaged and burning, the surrounding pelvic floor muscles are going to react instinctively by clamping down.
Right. To protect the injured area, it's a guarding mechanism.
But that constant, rigid muscle tension just cuts off blood flow and creates immense pressure, trapping the patient in a feedback loop of pain.
Exactly. And a specialized physical therapist interrupts that loop. They utilize targeted techniques like internal manual release and biofeedback to train the nervous system to let go of that tension.
So they're literally teaching the pelvic floor muscles how to stop guarding the inflamed urethra so the tissue can finally begin to heal.
Yeah, that's exactly it. And alongside the physical therapy, the sources highlight strict dietary and behavioral modifications.
And honestly, some of this protocol feels entirely counterintuitive.
How so?
Well, when urination causes blinding pain, the basic human instinct is to stop drinking liquids. You restrict fluids to avoid filling the bladder so you don't have to experience the pain of emptying it.
Right. But fluid restriction is actually one of the most dangerous instincts a patient can have in this scenario.
Because it concentrates the urine, right?
Exactly. Reducing fluid intake concentrates the urine, and highly concentrated urine becomes saturated with bodily waste products, making it incredibly acidic and caustic.
Oh, I see.
Yeah, when that concentrated acidic fluid passes over a raw, inflamed urethral lining, it magnifies the pain exponentially.
You are basically pouring concentrated acid over an open wound.
Pretty much. So the protocol actually demands at least 2,000 milliliters of water a day.
You want the urine to be as dilute as possible, acting like a gentle stream of water over a scrape rather than a chemical burn. Which brings me to one of the most fascinating contradictions in the sources. The cranberry juice myth.
Oh yeah, cranberry juice has been aggressively marketed as the ultimate cure-all for any urinary discomfort.
Right. But if you look at the Cleveland Clinic's official list of bladder irritants, cranberry juice is categorized as highly acidic. It is explicitly placed on the do not consume list.
It's right up there with the worst offenders.
Yeah, sitting right alongside caffeine chilies, hot sauces, tomatoes, and bizarrely bananas.
Bananas, yeah. The cranberry contains compounds that might help prevent certain bacterial UTIs by stopping bacteria from adhering to the bladder wall.
Sure, for an actual infection.
Right. But in the case of culture-negative post-injection dysuria, there are no bacteria to fight. The urethra is just physically inflamed.
So flooding that inflamed tissue with acidic cranberry juice is the equivalent of throwing gasoline on a fire.
Exactly. The clinical management requires total elimination of dietary irritants.
Okay, so the patient is hydrating aggressively with 2,000 milliliters of water. They've cut out all the acidic foods and caffeine, and they are working through pelvic floor PT.
Right.
For acute symptom management, the clinical guidelines suggest specific oral medications next.
Yeah, phenazopyridine is frequently prescribed as a first-line oral option. It offers rapid, albeit temporary, symptomatic relief from the intense burning and the constant urge to urinate.
But any clinician prescribing phenazopyridine has to issue a massive warning label to the patient regarding the side
Oh,
effects.
yeah, the color change.
It turns the urine an intense, almost neon orange. And it isn't just a startling color, it will permanently stain anything it comes into contact with: underwear, clothing, even the porcelain of a toilet seat.
And the clinical guidelines also strictly limit its use. Phenethylamine should not be taken for more than 3 consecutive days.
Right, because prolonged use allows the compound to accumulate in the body, which carries a risk of systemic toxicity. So 3 days of neon orange urine isn't a long-term strategy. But looking at the clinical trials provided in our sources, there is a compelling alternative that actually outperformed phenazopyridine.
Yes, a randomized clinical trial investigated a combination therapy utilizing 2 older pharmacological agents: methenamine at a 250 milligram dose combined with methylthionium chloride at 20 milligrams.
Okay.
The data demonstrated that this specific combination yielded a 12.7% higher extant response rate for pain reduction within the first 24 hours when compared directly to phenazopyridine.
Wow, that's significant.
Yeah, and what's fascinating here is the mechanism of action. These oral medications are not functioning systemically to heal the damaged tissue.
They aren't.
No, instead they operate as localized topical anesthetics.
Oh, I see.
They travel through the bloodstream, get filtered into the urine, and then actively numb the mucosal lining of the urinary tract from the inside out as they're excreted from the body.
That is a brilliant mechanism. They are turning the urine itself into a liquid painkiller. But let's follow the clinical ladder. What if the oral meds are just passing through too quickly?
Right. Like if the contact time isn't enough?
Yeah, I mean, the bladder is essentially a holding tank for harsh acidic waste. If the protective lining of that tank is severely damaged from the injection trauma, swallowing a pill that just washes over the area for a few seconds during urination seems incredibly inefficient.
It can be.
We need to treat the localized tissue directly inside the tank.
And that exact physiological obstacle leads to the next tier of clinical management: direct localized therapy. In urology, these are referred to as intravesical installations, or colloquially bladder cocktails.
Bladder cocktails. The process involves bypassing the digestive system entirely, right?
Right.
Liquid medications are pushed directly into the bladder through a catheter, allowing the inflamed tissue to literally soak in the treatment. Walk me through the pharmacology of this cocktail.
Well, the formulation is customized, but it generally targets 3 specific goals: immediate topical numbing artificial barrier protection and deep tissue anti-inflammation.
Okay, let's start with the numbing.
For the numbing component, clinicians rely on alkalinized lidocaine.
The alkalinization is key here, right? Because the barrier cells of the bladder, the urothelium, are incredibly resilient. If you just push regular lidocaine in there, it bounces right off.
Exactly, it doesn't absorb well.
But by adding sodium bicarbonate, you alkalinize the solution, which chemically forces the numbing agent to penetrate deeper into the urothelium.
Right, and that deeper penetration provides profound pain relief. But, it introduces a distinct clinical risk.
Systemic absorption.
Exactly. The deeper the lidocaine penetrates the bladder lining, the higher the risk that the drug gets absorbed into the systemic bloodstream. It requires precise dosage monitoring to prevent systemic lidocaine toxicity.
So the sodium bicarb and lidocaine handle the immediate nerve pain. But how do you protect that raw tissue once the cocktail is drained and the bladder starts filling with acidic urine again?
That requires repairing the glycosaminoglycan layer, or the JAG layer.
The JG layer, okay.
It is a protective, mucus-like coating on the inner surface of the bladder. Functionally, it acts exactly like the Teflon coating on a nonstick frying pan.
Ah, that makes sense.
Yeah, it repels the harsh chemicals in urine, keeping them away from the sensitive underlying tissue. In urethral pain syndrome, that JAG layer is often compromised or completely stripped away.
And to rebuild it, the cocktail includes heparin or hyaluronic acid, right?
Exactly.
The clinician is essentially injecting a synthetic Teflon coating directly into the bladder to artificially replenish that lost protective barrier.
Right. And the final and arguably most potent component addresses the underlying inflammation: DMSO, or dimethyl sulfoxide.
DMSO.
Yeah, DMSO holds the unique distinction of being the only FDA-approved installation for these specific inflammatory bladder conditions.
Oh, really?
Yeah, its primary mechanism is penetrating the bladder wall to degranulate mast cells.
The granulate mast cells, okay.
It effectively forces these immune cells to dump their histamines all at once, halting the chronic inflammatory cascade that is driving the irritation.
Here's where it gets really interesting. Because the clinical use of DMSO comes with one of the most bizarre side effects in medicine.
Oh yeah, the smell.
A patient receiving a DMSO installation will rapidly begin to exude a potent, overwhelming garlic-like odor.
It is intense.
It permeates their breath and literally secretes from their pores.
Yes, the garlic odor is unavoidable and highly documented. But beyond the smell, DMSO requires incredibly strict clinical timing.
Why is that?
The protocol dictates that the solution must only remain inside the bladder for 15 to 20 minutes. Because it absorbs so aggressively into the tissue, allowing it to sit longer, will ironically trigger severe agonizing pain and intense bladder spasms.
Wow, so it's a highly volatile chemical soak.
Very much so.
And these aren't one-time treatments. Patients often have to return weekly for months, undergoing repeated catheterizations to achieve any lasting repair of the bladder lining.
It's a grueling process.
Which forces us to ask the ultimate question. If the physical therapy fails, the oral nerve-numbing agents fail, and even the direct chemical soaks with DMSO fail, it implies the pain is no longer just a localized tissue issue.
Right.
The central nervous system itself has been altered. So how extreme do the treatments get for a refractory patient?
When a patient is completely refractory to localized treatments, clinical management escalates to the final tier, the heavy hitters.
The heavy hitters.
We move away from treating the bladder lining and start targeting the systemic nerve signaling directly.
We are talking about fundamentally altering how the brain and nerves communicate.
Yes, we utilize medications like low-dose amitriptyline.
Which is an antidepressant, right?
While originally developed as a tricyclic antidepressant at much lower doses, it demonstrates profound efficacy in modulating chronic neuropathic pain. Gabapentin is another frequent choice.
Okay.
The objective is to dampen the hyperactive nerve signals firing from the pelvic floor to the brain.
We are essentially trying to chemically turn down the volume knob on the entire central nervous system.
Exactly.
But what if the medication isn't enough? Our sources mention surgical interventions that sound borderline medieval, specifically NDYAA laser ablation.
The laser ablation is reserved for highly specific, carefully selected cases.
It sounds intense.
It is. If the urethral or bladder mucosa is so severely inflamed and fibrotic that it cannot heal the ND into, the NDIAG laser is utilized to physically burn away that diseased tissue.
You are intentionally causing a severe controlled burn inside the urinary tract, betting on the hope that when the body responds to this new massive trauma, it will finally lay down healthy tissue instead of inflamed scar tissue.
Right.
It's a brutal reset button.
It is an aggressive intervention. However, there is one more advanced therapy that highlights just how complex this management pathway becomes. Intratrusor Botox injections.
Like Botox?
Yes, Botox.
If local numbing doesn't work and we are dealing with a neuromuscular loop that is constantly firing, injecting the cosmetic wrinkle treatment directly into the bladder wall, how does botulinum toxin actually disrupt that pain cycle?
Well, botulinum toxin A functions by blocking the release of acetylcholine at the neuromuscular junction.
Okay.
In cosmetic applications, it paralyzes the facial muscles to stop wrinkles. In urology, it is injected directly into the detrusor muscle, which is the thick muscle forming the wall of the bladder.
I see.
By paralyzing the detrusor, it forcibly stops the relentless overactive muscle spasms that are creating the intense urgency and pain.
So you are shutting down the mechanical engine of the bladder so the nerves stop screaming.
Exactly.
But paralyzing the primary muscle responsible for pushing urine out of the body creates a massive mechanical failure. If the muscle can't contract, how does the urine leave the body?
It doesn't naturally.
Oh, wow.
This is the paramount clinical dilemma of using Botox for dysuria. Patients must undergo extensive counseling before consenting to this procedure.
I can imagine.
They must completely understand and accept the risk of urinary retention. The bladder becomes so relaxed that it simply fills up and cannot empty.
Which means the patient is now solely responsible for manual extraction.
Yes, they are required to utilize intermittent self-catheterization.
Oh my goodness.
They must physically insert a sterile tube into their own urethra multiple times a day, every day, to drain the bladder. And they must maintain this regimen for months until the neurotoxin slowly wears off.
The fact that a patient would willingly accept a reality where they have to self-catheterize 5 times a day just to escape the relentless burning of urethral pain syndrome truly contextualizes how debilitating this condition is.
It is a devastating quality of life trade-off.
Absolutely.
The willingness to make that trade, underscores the severity of the pain and the absolute necessity for clinicians to exhaust every possible avenue of the management ladder before arriving at that point.
So what does this all mean? Let's zoom out and look at the whole picture here.
Okay.
If you are navigating persistent post-injection dysuria, the clinical management is a highly structured, rigorous ladder. You don't just blindly swallow antibiotics. You start by challenging the standard 24-hour culture. You demand an expanded quantitative culture or next-generation sequencing to ensure a stealth bacteria isn't hiding in the margins.
Exactly.
Once an infection is definitively ruled out, you aggressively dilute the urine with 2,000 milliliters of water a day. You strip acidic irritants from your diet. You utilize pelvic floor physical therapy to break the muscle guarding loop.
And from there, you escalate to localized pharmacology using methenamine combinations as a topical numbing agent and intravesical installations to physically rebuild the damaged JAG layer and degranulate mast cells.
And finally, when the tissue simply will not heal you, confront the heavy hitters utilizing systemic nerve modulators, laser ablation, or accepting the severe mechanical trade-offs of paralyzing the bladder with Botox.
It's a journey. And if we connect this meticulous management ladder to the bigger picture, it reveals a fundamental shift in how we understand the body.
How so?
The reality that a single minimally invasive bulking injection can trigger a chain reaction, resulting in profound peripheral and central nervous system sensitization, is staggering.
It really is.
This raises an important question for the future of clinical medicine. If a localized physical trauma in the urethra can cause such widespread systemic nerve dysfunction that we are forced to rely on antidepressants and neurotoxins to quiet the brain's pain receptors, is it possible that the future of treating unexplained urinary and pelvic pain lies outside of traditional urology entirely?
Oh, wow.
We may need to accept that the real frontier is in neurology, in mapping understanding and ultimately rewiring how the brain interprets and amplifies distress signals from the pelvic floor.
The diagnostic tools might be looking for a biological invader that doesn't exist while the nervous system is screaming that the alarm system itself is broken.
Exactly.
We started this deep dive talking about the simple expectation of a clean fix like filling a cavity. But the pelvic anatomy isn't a simple mechanical plumbing system.
Not at all.
It is a highly volatile, deeply interconnected neurological ecosystem. And sometimes solving the medical mystery means realizing the problem isn't the invisible bacteria, but the alarm bells the body simply cannot stop ringing.
Very well said.
Thank you so much for joining us on this deep dive. Keep questioning the obvious answers, and we'll catch you next time.